Welcome to this webinar. We all here at Raghudeep Eye Hospital, Ahmedabad, India are very excited to interact with all of you across the globe. We do have a financial disclosure that we receive research grant support from Alcon Laboratories. And on this very fascinating topic of how do we optimize our risk benefit and get the best outcome in several situations. And I'm really delighted that my colleague, Dr. Shail Vasavada, is going to share the second half of the presentation. The first half involves understanding some basic fundamentals related to the phaco machine. How do we remove the cataract, the nucleus, and also how do we keep the bag clean at the end of the surgery. So as regard the phaco machine, the lens material is removed first by a process of lens fragmentation, and that's what is giving us the emulsate, and that's why the phaco emulsification is the name. So that fragmentation can be done with longitudinal ultrasound as it has been over the years. But in last several years, torsional ultrasound, which Alcon has a name given to it as an OZL or a torsional ultrasound, really has changed the way the lens is fragmented. And then this fragmented material is presented to the aspiration at the tip of the phaco tip. And the way that that fragmented material is aspirated is by two fundamental systems. One, very popular and widely used, a peristaltic system, which first step is attracting the fragmented material to the tip by a process called aspiration flow rate, slow or fast. And then once that material comes to the very tip, the vacuum generates in the system. So finally, that vacuum removes the material out of the eye. That's peristaltic system versus the Venturi system, where at one process, there are no steps of removal of the lens material like attraction and then building the vacuum as it was in peristaltic. Here in Venturi, straight away, the vacuum sitting in the machine, in the tube, attracts and removes straight away at the one step. Therefore, it's a little rapid or faster than the peristaltic, but each of the system has its own problems, and plus and minus. So let's look at that. And the AFR or aspiration flow rate, the attraction is by the speed of the pump, and that can be slower, as slow as 12 cc per minute with the phaco probe, or as high as 60 cc per minute. And then the vacuum builds up only and only when the material comes to the tip, unlike the Venturi, where it straight away vacuum is already existing inside the tubes and therefore attracts and produces little faster vacuum. But the real advantage of the peristaltic is that you can separate the attraction speed and then have the right vacuum. In other words, in a challenging situation, and Dr. Shail is going to speak on that, you can attract it very slowly, as slow as 12 cc per minute, 16 cc per minute, or whatever is comfortable and whatever is necessary in that scenario, and then have the appropriate high vacuum. You cannot do that in Venturi. Therefore, if you raise the vacuum, the safety will be compromised. So the real advantage of the peristaltic, and I think that's the reason it's being used very frequently or widely, is because you are able to separate the attraction flow rate from the vacuum. And this animation my colleague Dr. Vandana showed years ago, 60 cc per minute, and even a probe is not near to the iris and it catches because of the shear speed. And the same experiment she does it with 20 cc per minute, and iris doesn't come to the phaco tip. That's what the peristaltic aspiration flow rate is. But the key of the lens removal process is balancing the fluid going in and fluid going out. Input is by the bottle height with the conventional machine, and newer generation machine like Centurion, the bottle is not has given a height, but the fluid is pumped in by the pressure plate. So whatever the mechanism, the fluid going in has to be balanced with the fluid going out. The fluid goes out through the aspiration tube, which is aspiration flow rate, 20 cc per minute, 25 cc per minute, and also the wound leak, fluid leaking out of the wound, of the incisions. And when the surge occurs, there is additional fluid exit through the tube, which is known as an occlusion brake response. So this should be balanced. But if there is no occlusion, even in an unoccluded state, we need to be careful of avoiding excessive wound leak, tight, good incisions. Aspiration flow rate, if it is high, you must have a high bottle height. And if your aspiration flow rate is low, you must have a lower bottle height. Otherwise, there will be either low bottle height, low fluid, low input, or high input, which will upset the pressure gradient inside the eye. But notice the wound leak from the chopper or a side port. We don't pay attention to that, but the IOP will drop by 15 millimeter of mercury with such a leak. So you can understand the stability of the eye will be compromised. But the real question is, do we really want to pay much attention and focus it on input-output balance? In other words, the fluidics, as it's popularly called. Why? Because it does have a significant impact on the anatomy and the function of the various tissues of the eye. And I will present two studies to you, which we published, one in 2010, and we were doing it since 2007 or 8, these things. And in that study, we did two groups randomly. One, we used 40 cc per minute flow rate with the 90 centimeter bottle height. And the other group, we used 20 cc per minute and 65 centimeter bottle height. And we found that the eye, which had a lower bottle height and low flow rate, used more fluid, did more clock time, and had to have more energy. But we could confine the lens removal process away from the cornea in that group. While in the higher flow rate of 40 cc group, we finished quicker, less fluid in and out, and less energy. But the best part is that when we looked at the cornea, inflammation, and IOP on the day one, the eyes with the lower parameters did much better. They had a clearer cornea, less inflammation, and less IOP rise, in spite of more energy going in the eye, more fluid going in the eye, and more time taken. So in other words, it's like driving a motorbike or a car. Higher speed, obviously you will go faster, but you are risking your potential to make an accident. That's what you see on the motorways for years. But the second study really was very interesting, and we could discover why we found that the lower parameters of flow rate and the bottle height gave a better outcome to the cornea and the antisegment. Is because the higher flow rate and bottle height were associated with higher intraocular IOPs, up to 80 plus millimeter. And we recorded that live dynamic during the surgery by introducing the intracardiac sensor devices. So higher flow rates really is something we want to avoid for the impact of the eye. And you can understand the trabecular meshwork dysfunction, the macular cones and macular edema, endothelium, and so on. So I think we, for one, are convinced that as low but as high as your efficiency allows. So in good old days, the technique like slow motion technique, which used very low bottle height and flow rate, didn't work well because it took a long time. It was very tedious for the surgeon. But with the torsional ultrasound, because the material remains at the tip, these lower flow rates could compensate for the lack of speed. So the efficiency or the speed was not compromised, and still we could remove the fragments and the lens away from the cornea. So safety was added by these dorsal component, and therefore lower parameters now are the in thing. And as you could see on the screen, on the left side, the flow rate is 40 cc, more fluctuations of the graph, and you can see that again there, that on the left side there are more dips and more fluctuation, while on the right side, this process is a little slower, of course, but not that slow, sufficiently fast. But look at the fluctuation, minimal fluctuation on the right side, because the flow rate is 20 cc per minute and the bottle height is low. So that's what you want to keep in mind, understanding the machine. The nucleus, when you remove, has distinct phases. If you are doing a sculpting, and we recommend that to create a space, and then divide, and then remove the divided fragment. Each of this stage has a distinct objective, and therefore has a different parameters like the bottle height, the flow rate, the power, and the vacuum. Whatever you do, it makes sure it's reproducible in your hand, it's predictable every second of the procedure, and it obviously at the end very safe. Principally, a simplified way, there are two ways to remove the nucleus, doing a 4-quadrant technique, or a sculpting, as we call it, or chop technique, dividing with the help of a vacuum-based hold of the lens. The first example of a sculpting involves creating a trench or a space. And notice on your right-hand side, the parameters here, the IOP 30, which translate to 54 centimeter bottle height. Only 54 centimeter bottle height, mind you. And the flow rate is 14 cc per minute. And the vacuum is only 40 millimeter of mercury with a 10 or 20% preset vacuum, preset torsional ultrasound on a burst mode, 200 millisecond every time the burst is fired. So you take your time, and then the trench is made to your liking. So that is safe because the flow rate is very low, the vacuum is low, and you can create 4 quadrants like this, taking your time. This works very well every time, irrespective of the density. This works. It's a universal technique, and I recommend that. It's the best suited for soft cataract, but even if it is not soft, some cataract which are not soft, not very dense, this is the technique if you are not very familiar with the chop technique. I love chop, and I do chop technique all the time, but this is a very useful, very, very important, and a very good technique. Once you divide, you need to be careful about the plane at which you're removing. Try to be away from the cornea. Notice if the parameters, once again, 40 IOP, about, once again, 58, 60 centimeter bottle height, 20 cc flow rate, and appropriate vacuum. So take your time, and it's done in a very controlled manner. But it is a chop technique which is very useful and reduces the energy delivery, and the Nagahara came up with this concept of horizontal chop, which can be done without creating a space, also known as a direct chop. And then Dr. Koch modified it to stop and chop. We brought out for the first time what we described chop in situ, but then it was labeled as a vertical chop. And this is what that chop in situ we published in 96. We were doing it for 2 years earlier than that, which involves occluding it and then making the chop movement vertically, as you will see here. What I'm doing now here is that I buried the phaco tip here, the foot paddle here is in second position, and the chopper initiates a crack, and then with lateral separation, that has been separated. You will notice it now again. My foot paddle here is in third position, so I'm entering the phaco, the lens material. Once I enter and occlude completely, I will bring my foot paddle to second position. Now you can see the second position. And once the preset vacuum is achieved here, I will depress the chopper vertically towards the optic nerve to initiate the crack, not to aim total crack at this stage, and then separate it with a lateral separation. So that's what we described long back, but it is appropriately called vertical chop. In a denser cataract, you need to go even slower than that, and therefore the principle of going graduated way or a step-by-step way is very important in all aspects of lens removal, but particularly when you divide in this chop action. And this animation shows it. Occlude the tip, bury it, and then gradually initiate the crack and extend this crack in a step-by-step manner posteriorly to the very bottom plate, which is very tenacious in many dense cataract, and then produce a lateral separation. And you need to repeat this action all 360 degree and produce fragments of that hard cataract. And once you do that, you proceed to the next stage of the lens removal, which is the fragmentation. And this one more example of a very dense cataract. Notice the foot paddle here. The foot paddle is in one irrigation position. Now I'm going in a minute to the third position. I'm burying the phaco tip with energy. And once it's achieved, I will come off to the second position, and the preset vacuum is reached here, which is 700 here. It shows occlusion. My aim now here is to initiate the crack by depressing the chopper vertically towards the optic nerve. The right hand remains still, and then reposition the chopper into the depth of the crack and produce a lateral separation to create a total division peripheral to the central and anterior to the posterior. And likewise, the whole process is repeated all around. Sometimes this doesn't work. So we devise a further modification, which is useful at times. You don't need every time, but that chopping principle applied at different levels is called multi-level chop technique, and it really ensures a total division. What it means is that you start a crack at the right plane and then re-bury it, take it out and bury it again at a deeper level, and then apply the division forces. Why we need to do that? Because in very dense cataract, the bottom plate is very resistant to the separation. And if you try to divide the bottom plate working from the front of it, you need to tort the eye so much. So apply that at one level and then go back to the deeper level closer to the bottom plate. So your separating forces are minimized. So in a compromised zonules or in a bulky cataract, the bag is overstretched. This principle of multi-level chop really has a very good advantage that the zonules are not affected. So I'm burying it and producing an initial crack at one level, and I'm just doing that now. I can continue that, but this bag has a compromised zonule. So now I will take this buried tip out of the lens material and then re-bury it again at a deeper level. You will see that in a minute. I'm taking it out, and then now again, I'm going at a deeper level and apply my division forces closer to the bottom plate so that I don't have to use a lot of lateral separation principles. Whatever the technique you have, remember the end point of the second stage of this lens removal, which is division, is multiple fragments. Denser the cataract, more the number of fragments that we need to do. Now, the fragment removal is the one which is very crucial, which will decide the clarity of the cornea. In a torsional ultrasound, unlike the longitudinal ultrasound, where the flow rate, where the fragmentation pushes the lens material away from the tip, as in a longitudinal ultrasound, the aspiration has to overcome that repulsion or energy or the push, and therefore you need to have a higher flow rate. In a torsional ultrasound, the material remains at the tip. Therefore, both these forces work in harmony and synergy, so you can use the low flow rate and sufficient energy. This high-speed photography, which my colleague Dr. Sambharesh Srivastava produced, what we call it carousing, like a torsional, the lens material remains at the tip. This is at a very high-speed photography showing what the torsional ultrasound can do. My left hand is steady, but the lens material gets repositioned all the time at the phaco tip. That's what the torsional ultrasound does, and that enables us to keep the flow rate low and still achieve the efficiency. Phaco energy can be modulated by pulse mode or bus mode, whatever you do. What matters at the end of the day, what matters to the clarity of the cornea and other structures and the segment is the total amount of energy you spend, which the interrupted energy will help you to reduce. But two other important things, how much time you take to deliver. Longer you take to deliver the same amount, better it is. A 1 millijoule energy dissipated in 1 second versus 1 millijoule in 2 milliseconds is better, 2 seconds. And also if you do at a posterior plane, which I mean the plane beyond the iris, is better than anterior plane. This is anterior plane. Even if you reduce the energy and spend less energy, this is more detrimental to the endothelium versus the posterior plane, where you may take more time, more energy, but it's away from the endothelium. So remember, go slow, be conscious of the plane that you remove, and the intraoperative osity illustrate that, these fragments touching the endothelium from time to time. You'll see here, coming here, and that's what, it doesn't look on the video here. You think it's okay, but the intraoperative wants you, red light goes up, and you are in the dead zone. So be careful of that plane of the emulsification. And finally, if you more and more posterior capsule get exposed, you need to keep your aspiration flow rate in a vacuum low, but do not lift the phaco probe up. A common tendency is to keep the phaco probe up and up as more and more posterior capsule get exposed and more red glow appears. We are scared of rupture. So we are not changing the parameters, but we change the position of the phaco probe and bringing anteriorly. Instead of that, do not bring any phaco tip near to the cornea, but reduce your parameters of particularly flow rate and the vacuum. Now, having understood the basics, I would request my colleague, Dr. Shail, to take us through the difficult scenarios and challenging situations that we all are eager to learn and produce a consistent outcome. So, Shail, please take over.
Hello to everyone from my side. I think having understood these basics, now it becomes quite clear that it's more just a play of how these principles are managed from a case-to-case scenario, rather than having to learn a special technique for each special kind of a cataract. I think this is one situation which most of us, particularly in our part of the world, are very blessed with, that is extremely dense and extremely advanced cataract. So this is, even with the most high-end microscope with complete coaxial illumination, this is the kind of cataract that is being presented. That is what we typically describe as a black cataract or a brunous and black cataract. So notice here, the advantage of the peristaltic system, which was discussed earlier, that we are able to regulate the flow rate and the vacuum independently. So therefore, because this is an extremely dense cataract, we want maximum vacuum. However, we don't want too much of an attraction in this situation. So we've kept a flow rate of 20 cc per minute with the vacuum which goes up to as high as the maximum, that is up to 700 millimeters of mercury. So once it's occluded, you go ahead, you try and divide the fragment. Don't try and complete the crack in one go. You can achieve it from time to time, but reposition your chopper and try and extend the crack completely. Try and complete this process 360 degrees on each part. Now, the reason why you want to make sure that you divide the lens completely is that quite often the posterior plate in such leathery cataracts, you can see here some of these fibers, they are so difficult to be separated that they will actually be attached at the bottom like a flower petal. And then when you try to remove them without actually dividing them, it can lead to a disaster. So this is actually, I've already completed one round of chopping, but I know that one round of chopping is not going to be enough for this case. So I'm making sure once again that all the fragments which I think are divided are actually divided. And to my surprise, what I found here was that there was a posterior plate which was still attached. So reconfirm whether each fragment is actually divided rather than being in a hurry of removing it and finishing the surgery quickly. Because even if one fragment is undivided, the cornea can be very, very different on the next day. Once you have made sure that the fragments are removed, divided, what you notice here is that we first go ahead, bring the fragment in the center, then detach the fragment, and notice my right hand is very much steady in the center of the eye. So whatever repositioning may be required would be done with the left hand. Now again, in such situations with a very dense cataract, however good techniques you may use, you also need supplements. That is to protect the corneal endothelium, and this what we are using here is a dispersive viscoelastic, typically Viscoat commercially available, which is nothing but chondroitin sulfate, which sticks to the corneal endothelium and prevents corneal endothelial damage as much as possible. So it's not enough to just use viscoelastic once before starting. If multiple times during fragment removal in dense cataract, you need to keep topping it up with dispersive viscoelastics. Notice once again, you bring the fragment to the center, then you detach the fragment so that the tip is actually on the side and on top of the fragment rather than burying it, so that there is no complete occlusion at any time point. And then you go and make sure that whatever movements that are being done are only with the left hand. If you avoid moving your phacoprobe too much in different directions, the advantage is that the fluid will not go to different directions, because if you move your probe closer to the iris, sometimes the fluid can actually go behind the iris, and that's what we typically see or describe very often as the iris keeps prolapsing or the iris became floppy during the surgery. But if you maintain and make sure that the phacoprobe remains as central as possible during the fragment removal, the chances of that occurring are quite less. Now, a case of a high myopia. The problem in high myopes is that very often they do have a very, very central dense nucleus. And the other problem is that because the scleral rigidity of these eyes is so low, the chamber is sometimes becomes very deep in spite of all the fluidics that you use. So this is a case of a black cataract, and notice the parameters here. So we have reduced the IOP to 20, the lowest IOP, that is equivalent to a bottle height of about 30 centimeters. The flow rate is once again, like I said, only 20, but with a maximum vacuum that is required to hopefully chop this nucleus. So you can titrate each parameter independently, which would probably not be possible to do so effectively in a Venturi based system. So in a high myope, the first advice would be to keep the bottle height as low as possible, because you don't want the chamber to keep inflating too much. The other thing that you want to keep in mind as far as a high myope goes is to not keep going from foot position 1 to 0, 1 to 0 very often. Because what that does is the eye collapses, the eye forms again, collapses, forms again. That causes a lot of stretch to the eye, that is discomfort to the patient, which is typically seen as patients shouting inside the operating theater. And what it also avoids too much of trampolining of the anterior vitreous phase, which often leads to anterior vitreous detachments, which can have long-term sequelae in these patients of high myopia. So we are working constantly at the low IOP of 20, and notice once again repositioning the chopper. The aim is never to complete the crack in the first separation. You may have to repeat this multiple times at multiple levels, and at least 2 to 3 rounds of chopping to actually make sure that all the fragments are completely divided at the posterior plate. Notice how we are constantly repositioning the chopper until we are absolutely satisfied that each and every fiber of the posterior plate is completely divided. And having done that, even during fragment removal, although there will be more fluid that may be required as we are aspirating more, you can still work with a very low intraocular pressure or a bottle height. 30 IOP is equivalent to about 40-45 centimeters of bottle height. In a high myope particularly, I think this is very important that you work at lower parameters or lower bottle heights. You'll still be able to not only maintain the chamber, irrespective of the machine that you have, and therefore you will be much more comfortable operating rather than operating too deep, where often your hands, you are unable to reach with your hands. Your chopper keeps depressing and leads to folds on the cornea. So low bottle height or low intraocular pressure, along with appropriate vacuum and appropriate flow rate, is something to keep in mind, particularly in cases with high myopia and dense cataract. So I think the points to keep in mind as far as a very hard cataract is to aim complete division, go for a step-by-step approach. Make sure that you have created multiple fragments before even attempting to remove a single fragment. Try and keep the fragments as posterior as possible, and like I showed, right in the center of the eye rather than moving towards the different fornices. And repeated use of dispersive OVDs or viscoelastics. So even if you are not using it as a routine in all your cases, I would highly recommend to keep a dispersive viscoelastic in your operating theater, which you should definitely use in cases of a hard cataract. Once all of this is removed, that is all the fragments are removed, what we are left behind is with the cortex, and that is something that is very often neglected. The cortex removal, it's just considered as a one-step vacuum go. But I think it's important to understand that like in lens division and removal, cortex removal also consists of several steps. What we described as a clean sweep technique, which is under peer review. So just to remember the steps of cortex removal, just remember the acronym POPs. That is, first you make sure that you position your aspiration probe, whether it's coaxial or bimanual, just under the anterior cortex. So you don't want to go right in the fornix, and you don't want to start in foot position to right from the center of the eye. So first important is to position. And why is that important is that if you often are in foot position 2 before you reach the cortex, and if the pupil is semi-dilated, before you can catch the cortex, you end up catching the iris. And then the iris keeps coming down, pigments keep getting released, and then cortex removal becomes extremely difficult. The second step is O, that is occlude. That is, once you position it, then go to foot position 2, so that now you have actually just about occluded the cortical matter. Once that is done, what you need to do is actually posteriorly detach it. So if you can see here, it's difficult to show in a two-dimensional video, but if you keep noticing this part of the animation, once you occlude it, you actually use your aspiration probe to detach it from the anterior capsule surface, which will allow you to make the next step of removal much easier. That is to make a side-to-side or a swiping movement. Now, the reason why we want to consider doing a swiping movement is, one, it produces less stress on the zonules. So a direct radial pull causes a lot more stress on the zonules compared to a swiping movement, which was very nicely shown by Dr. Liliana Werner and Dr. Alan Crandall in the Miyake View experiments, where they compared the hurricane cortex removal technique. What the other advantage of swiping is that it will allow more equatorial lens epithelial cells to be removed. And that is actually the source of the PCO that occurs. So even if you leave behind few fibers on the posterior capsule, they are not going to proliferate and cause PCO. It's the lens equatorial epithelial cells in the fornices which are going to proliferate over a period of time and cause PCO. So swiping movements helps in both ways. And only once that is done and you bring it to the center, do you step up on the vacuum and remove it completely. So until that time, your foot position, although you are in 2, you don't go into full foot position 2. You go into full foot position 2 only once you actually detach the cortical fibers. So this is another beautiful experiment done by my colleague, Dr. Samresh Srivastav, to show that when you actually go ahead for a radial pull, not only it causes a lot of stress to the zonules, but there are chances that the cortex sometimes tends to break off, leaving behind not only residual cortex, but also residual lens equatorial epithelial cells. Compare that to a step-by-step cortex removal, that is positioning, occluding, swiping, and then actually removing. You are less likely to cause stress to the zonules and more complete removal of the cortex and the lens equatorial epithelial cells. Having understood dense cataract management, the dreaded cataract that all of us have nightmares before going to bed when you have this in the list the next day, that is posterior polar cataract. And the reason is that we are always worried whether this capsule will hold on during the surgery and whether you're going to need the help of your vitreoretinal colleague or not. The first step or the first pearl that you need to keep in mind is that any form of hydraulic pressure through the cortical area is likely to cause a posterior capsule rupture. So no form of hydrodissection should ever be attempted in posterior polar cataract. So the classical subcapsular hydrodissection should be avoided, and either conventional or modifications of hydrodelineation need to be done. The second important pearl is that we need to create multiple cushions so that when we are removing the lens material, there is very little mechanical movements that are required of the lens, and therefore less need for rotation of the lens and chances of that stress radiating to the posterior capsule. In conventional hydrodelineation, there are chances that inadvertently you may end up causing some subcapsular hydrodissection, however experienced you may be, and this often occurs in either extremely soft jelly-like polar cataracts or extremely dense, where it's almost very difficult to actually go inside the nuclear part. So we describe a technique known as inside-out delineation, where first you create actually a trench. So you first create a sculpting trench and go inside the trench to do the hydrodelineation, so that the chances of causing an inadvertent hydrodissection are very minimal. The surgical video to show the same, a sculpting has been created, and then you go with specially designed angled cannulas right and left, and then you inject the fluid in as many areas that you feel like. So you inject it on this side, you may need to inject it on the other side, and therefore you are more sure of creating a hydrodelineation and a cushion effect. By cushion, what I mean is that the final epinuclear part remains confined, so that you remove rest of the nucleus in that cushion. The third is prevent forward bulge of the capsular zonular complex, and by that we mean whenever you remove any instrument of the eye, do not allow the chamber to collapse. So even now when we want to do hydrodelineation, when we remove the probe, make sure you fill up the chamber with a dispersive viscoelastic, because dispersive viscoelastic is retentive and it stays there, so that there is no forward bulging of this capsule, which can also, sudden changes in the intraocular pressure can also lead to a rupture of this posterior polar capsule. And the third, while during irrigation aspiration, particularly if you are doing bimanual, which I would strongly recommend in such cases to avoid distortion of the wound and shallowing of the chamber, even when you are changing hands in bimanual irrigation aspiration, make sure that the chamber is formed. The fourth important pearl is to create a communication between the anterior and posterior compartments. And by that we mean that when we come to epinuclear removal, what we are doing here is, notice we are actually just detaching the epinuclear plate from the fornix, but we are not going to completely remove that. Why we do that is that by detaching it, now we have created a communication between the anterior and the posterior chamber. So small amounts of fluid will start trickling down now towards the posterior capsule. And this will now make sure that there is no sudden rise in the intralenticular pressure. So at this stage, you can even go ahead and perform hydrodissection if you feel this epinuclear plate is too thick to be removed. The fifth, something that we find very useful, is the use of femtosecond cataract technology, where the same principle of hydrodelineation is done with the femtosecond, where we create multiple zones of lens division, or this is like doing 3 inside-out hydrodelineations. And we prefer the cylindrical lens division pattern for the same, so that when each cylinder or each zone of the nucleus is removed, at all points the posterior polar part is always protected until the last epinuclear part is removed. So each nuclear zone is removed from the cushion of the other. Therefore, chances of mechanical stress and hydraulic pressure buildup are minimal. And what we found was that our rupture rate has gone down significantly from 8 to 12%, which we reported with inside out delineation, to less than 4% with femtodelineation. From conventional to inside out to femtodelineation. And this is a surgical video to show the same, that each zone of the pre-divided nucleus is removed from the cushion of the other. So at all points of time, the last part or the epinuclear part which contains the posterior polar part is always well protected. Because femtosecond produces vertical cuts, these are usually easy to scoop out with a chopper like this. So you can actually scoop it out because the walls are vertical. And until the last point, you can actually protect the posterior polar part. The rest of the steps remain the same. Now coming to another important, not a very, not the most complicated situation, but something that we encounter more frequently than any other difficult situation, that is a small pupil, either to start off with or what we end up with during the surgery. So I think the first pearl as far as small pupil is that have adequate exposure. So there is no shame in using any pupil expansion devices, no matter whatever stage of your career you may be as far as cataract surgery goes. There are several ways to dilate the pupil. The iris hooks being the most common and the most well-time tested things. Now there are several rings also available. We have our own Dr. Suben Bhattacharya ji from Calcutta, who has made the B-Hex pupil expansion device, the ever popular Malugan ring, and so on and so forth. We prefer the iris hooks for the simple reason of ease of insertion and the fact that iris hooks can actually be used at any stage of surgery. So most of these ring devices like the Malugans and the B-Hex and their various modifications, if you don't use that ring before doing the capsular X's or before starting the lens removal, midway during the surgery, it's very difficult to introduce many of these rings, and removing them can also be challenging. So there are merits and demerits of each. We prefer the iris hooks to work well in our hands. The other few tricks that you need to keep in mind as far as iris hooks introduction goes is that you make sure that the location and angle of the incision are appropriate. So you don't want to be very scleral, because then the angle of insertion will be too much parallel to the limbus, which will make it very difficult to actually dip the iris retractor. And the second is you don't want to make the chamber too deep before actually wanting to introduce the iris hooks. So make it close to the limbus, not the full thickness side port incision. So notice I'm introducing only about half of the side port. That's all what is required to introduce the iris hooks. And once, typically 4 are enough, but you may want to use 5 as well in a special situation. This is what I mean by not keeping the chamber very deep. Notice that if the chamber, if you have filled it up with too much of a cohesive viscoelastic, you will actually struggle to actually reach up to the below the iris to cause and retract the iris. So make sure that the chamber is not very deep before you actually, if you have decided to introduce retractors, go ahead with them straight away. And the chamber should be adequately formed, but not very deep. This is typically that most of us are used to doing, where we start off with a reasonably dilated, not a well dilated, not an extremely small pupil, and you think you would get away without using retractors. And here the only key is the boxes on the right side. So if whatever parameters that you are used to using, make sure that you use much lower than what you are used to in a normal situation. So if in a normal situation you are used to using 110 centimeters of bottle height, drop it to 70 or 80. The reason why I say that is that some of the excessive fluid will actually go behind the iris. That will cause a change in the pressure gradient between the anterior and the posterior segment and lead to iris prolapse and further constriction of the pupil. The second important point in such situations is to make sure what we already discussed, to remove the lens matter right in the center of the eye rather than close to the iris. So your probe, your energy delivery, and your fluidics is working in the most safe zone of the eye without causing any turbulence, any changes to the iris and to the other structures so that this pupil remains of the same size until the end of the lens fragment removal procedure. This is something that inevitably happens in patients, particularly with using prostate medications. It also happens in high myopes, what typically is described as floppiness of the iris or the lens iris diaphragm push syndrome. The principle here is to make sure that by the pressure gradient between the anterior and the posterior chamber is well maintained. By anterior and posterior, we mean above the iris and below the iris. So any excessive fluid or OVD, excess use of OVD is something that is often we miss out. We feel that the iris is, the pupil is small. Let's use some more OVD to try and dilate the pupil. That actually works in a counter way, and it actually sometimes goes behind the iris, pushing the iris from below up, and therefore it starts tenting up to the side port. Now keep noticing this case. It starts off with a well dilated pupil, and keep noticing the shape of the pupil here at the side port. Slowly you will start noticing that there is a gradual ovalization of the pupil that is occurring. And soon enough, what you'll also realize is that along with the ovalization, once this fragment is removed, you'll realize that the pupil is actually now coming and hitting the side port and actually peaking. And now this means your iris has started to prolapse. So at this stage, what we do is we try and push. We try to use this instrument, bring it out and push the iris in. Never do that. Two things that you can do. First is notice what I'm doing here. I've gone in foot position 0. Therefore, now the chamber is allowed to collapse. Now I've reduced my bottle height from 40 to 30. So reduce your parameters, and by reducing the parameters, notice how the pupil goes back to your normal location. And then once it is gone back to its normal location, all through the surgery, we were able to manage without the iris coming at any stage or any point. Keep noticing the fluttering at the iris. So this is a floppy iris, but to say that once the iris prolapses, it will always continue to prolapse throughout the surgery is something that can easily be modified, particularly by changing your parameters. So even if you start off with the wrong parameters, you can always drop them down. And if in case you want to reposit the iris, never use the same incisions. For example, if I want to reposition the iris here, I would use a dispersive viscoelastic from the opposite side port and push it over this iris so that it doesn't prolapse any further. So use low bottle height and aspiration parameters. This is even more critical in patients with small pupil and shallow chambers. So by increasing the bottle height in a shallow chamber, the chamber is not going to deepen. In fact, it will go behind the iris, lead to iris prolapse, further shallowing, further small pupil, so on and so forth. So achieving adequate exposure and maintaining pressure gradient. And finally, just a touch up on IOL selection in post-refractive surgery. I think there are 3 points that are very crucial. First is IOL power calculation using modern generation formulas. We prefer the ASCRS online calculator, out of which Barrett's True K is the most accurate that we find across all situations. As a rule, multifocals are not the IOLs of choice because most of these LASIKs were done with the older generation laser machines, and quite a lot of their ablation on the cornea are decentered. Therefore, they already have a lot of corneal aberrations, and adding more aberrations with a multifocal IOL may actually worsen the quality of vision. And the third is, in spite of doing everything, you may still end up with a refractive surprise. So never promise the star and moons to these patients because they are the ones who actually want. That's why they got LASIK done many years ago. So please counsel them preoperatively about the possibility of a refractive surprise. I'm sorry, beg your pardon for that typo error. Refractive surprise after the cataract surgery, for which they may require the use of selective glasses. I would like to end my talk at this point of time, and I think we have time to go through the questions that may have come up during these presentations, or the points which we may not have been able to answer adequately.
One of the questions which is relevant to many parts of the world is that is phacoemulsification more dangerous than extracapsular for very dense cataract? I think the question is very valid. And in the beginning or in the evolution of our experiencing and developing an expertise on phacoemulsification, I would advise you to consider extracapsular or small incision manual cataract surgery. So in the beginning, I think there's no shame in doing a large incision extracapsular or a small incision cataract surgery, but once you develop a consistency in phacoemulsification, you will be able to do a much better job, even in a dense cataract or all of these myriads of challenging situations, some of which we dealt today. So it's a matter of individual training and experience, but on the whole, both the techniques are very good. Pursue with whatever you are familiar with. We are so happy with phacoemulsification that I don't remember when I did extracapsular surgery in any of the situations last. Now, there is a question here. During sculpting, sometimes less tilting, lens tilting and moving, how to prevent it? If you make sure that your phaco tip or a bevel is unoccluded, if your phaco tip gets occluded with the lens material, it will rock the lens and it will move and tilt. And also you will waste your energy, phaco energy, and you will produce phaco burns to the incision. So keep your phaco tip unoccluded. Concentrate and look at the phaco tip bevel, and you will be fine. Sometimes we get unequal sized two quadrants after sculpting. How to prevent it? I think that's very true. Make sure and orient with your proprioception the location of your incision. If your incision is little to the temporal of the midline, which I do it, your hemisection and your sculpting should also be appropriately. If you locate your incision temporally and do vertically, obviously it will be of a different size. There is a question from John Davis, Akara. Can EDOF IOLs be used in a post-LASIK patient? Dr. Shail will answer this question. Most of us believed when it was said that EDOF IOLs came that they are less damaging or better quality of vision compared to multifocal conventional IOLs. However, the current generation, all the lenses that are so-called EDOF are actually low power add multifocal IOLs, like the Symphony, like Restore 2.5. Yes. So there is no true EDOF IOL available as of now. And I think for most post-LASIK patients, any form of multifocal technology, whether it's EDOF or traditional, as a rule is no. There will be exceptions, but as a rule, I would say no. What about aspheric and spheric?
About aspheric and spheric IOL. So what happens is that whenever most of these patients are post-myopic LASIK, which means that we increase the spherical aberrations by flattening the cornea, and therefore aspheric IOLs would definitely help in some ways or the other to try and improve the quality of vision.
And vice versa, if in the hypermetropic LASIK correction, do not put aspheric, but use a simple spheric IOL. But avoid multifocal, as Dr. Shail said. The other question, Muhammad Osama, the question is, what is femtodelineation? I think it is just like a fluid delineation or hydrodelineation. The same process of creating multiple cushions is done by femtosecond laser, and therefore it's known as a femtodelineation. It's just the terminology, the same thing. So that's one. We have one situation here. How do you manage LIDRS syndrome in myopic eyes? In other words, those who are not familiar, the pupil comes down and dilates, the chamber shallows and deepens suddenly. And that's because the eye has a low rigidity. It's called compliant globe, and a little bit of extra fluid than the stretched globe can take will make the fluid go behind the iris, and that will produce the flutter of the iris. So one thing to prevent is to use low parameters, low bottle height, minimal infusion, and that's what you saw, a 28 cc bottle height, 28 centimeter. and then lift the iris. Put a spatula behind the iris, and if you lift it, the fluid will come out from behind the iris to the front. The next question is, during phaco, if you end up with a ball-shaped crater, how do you proceed? Well, if it's a soft cataract, you have a problem. Therefore, make sure that you use a very small trench and less energy. If you have more preset energy, you will remove more lens material. So minimal femto or the phaco energy to create small trenches. If it's a hard cataract, it's a welcome thing to do because you already have debulked the central hardness. So the short answer is low preset energy and go slow. There's a question here by Dr. Shivika Agarwal, how to manage aspiration and vacuum when you have no torsional phaco and still get low corneal edema. I think that's okay if you do not have a torsional. Use less preset energy, number one, and aspiration flow rate. If I'm using 20 cc with torsional, you may get away with 25 cc per minute, but do not use more than 25 cc per minute flow rate in a longitudinal ultrasound. And the vacuum will depend on the density. If the cataract is dense and it demands 500 vacuum, use it. So vacuum is not critical. The critical is the flow rate. Higher the flow rate, you will aspirate the capsule, posterior capsule, and iris more often. So reduce the low flow rate. So flow rate low, but not very extreme. Mohammed Osama, thank you. Okay, now can you bring up so that I can see more? There's a question from Husna Naufal. Question is, can we decrease bottle height and use low parameters if cataract is denser and small? Absolutely. I'm glad that you're asking it, and I would re-emphasize that's the way to do it. Now, the next question is here, and that I think we addressed multifocal lenses in the post-refractive surgery, so that's fine. Okay. I'm just going through the questions, if I have any here, which I've missed here. There's a question about the traumatic cataract. There's just a comment that can you speak something on traumatic cataract? In 2 minutes that I have a closed chamber technique, use high density cohesive viscoelastic like Heal-On GV or Heal-On 5, and use retractors, good visibility, trypan blue staining, and keep the anterior vitrectomy machinery ready. You may need it anytime. So it needs some expertise, and do it in a routine OT time. Do not do it at late nights, traumatic cataracts. You will not be most efficient. And do not let it go to the junior most person, which usually the story in a very large, high volume practice. So I really can't thank you. And I thank Dr. Shail and all of our staff here, Jankana and others, Pritesh and REH, Raghudeep Eye Hospital staff to organize this so well. I hope you enjoyed as much as we enjoyed here at the SAN. And thank you, Orbis, for the arrangements. Thank you.